This is Kelly Neal again, and now we're going to be learning about third-degree heart blocks. So when we're talking about a third-degree heart block, it's also known as a complete heart block or AV dissociation because the atria and the ventricles are completely working separately. There's no connection between them anymore. So what we're saying by this is that the block in the AV node is complete. None of the sinus beats penetrate the AV node. As an escape mechanism, either the junction or the ventricles are going to kick in to depolarize the ventricles to generate a cardiac output. So if you think about it, if your SA node is firing okay and the impulses are getting to the AV node, but the AV node is blocking them from going down the ventricles, your heart wouldn't be contracting and you wouldn't have any cardiac output. So either the junction will kick in or the Purkinje fibers themselves will kick in as a backup system. So you'll see what looks like a junctional rhythm or an idioventricular rhythm going at a regular rate. And you'll see all these sinus P waves, but there will be no connection or link between them. So the sinus node's going to fire at a rate of 60 to 100 beats per minute. We're going to see normal P waves. The impulse stops at the AV node, so the ventricles, we said either the junction will kick in. Now if the junction kicks in, we'll have a normal QRS size and we'll have a heart rate usually of 40 to 60 beats per minute. Or the ventricles, the Purkinje fibers can kick in for the ventricles, also giving us a regular R to R, but we'll have that wide bizarre QRS that's over 0.12, usually within a rate of 15 to 40. So there's going to be extra P waves. If our P waves are firing at a rate of 60 to 100 and our QRS is going at a rate of either 40 to 60 if it's from the junctional source or 15 to 40 if it's coming from the ventricles, we will definitely have more P waves. But there isn't going to be a relationship, and the way we know that there's a relationship between the atria and the ventricles is the PR interval. Now this is also known, as I said, a complete heart block or AV dissociation because they're each doing their own thing. Now, when we look at a third-degree heart block, so we see here from P wave to P wave to P wave to P wave to P wave, P to P to P will march out. And sometimes that extra P wave is going to get lost in the QRS or it's going to get lost in the ST or T wave section. It doesn't mean it's not there. Find two P waves you can easily see, and then you will be able to space them out, and you'll see the extra hidden P waves. So I have more P waves than I have QRSs. Then I look at my R to R. QRS to QRS to QRS to QRS is also regular. So now I want to know, is there a relationship? When I see more P waves than I see QRSs, I'm definitely thinking I have a heart block. I just want to know what type of heart block it is now. So I go to that PR interval, and my P wave to my QRS, that measurement, is completely different than this measurement. Here I have my dropped beat. I have this measurement. And I have this measurement. Now, granted, you would normally have a longer strip. Now, the two most common heart blocks that people confuse is a Winkie-Bach, a second-degree type 1, and a third degree. Because if you look at this one here, you're saying, okay, but my PR interval, it's short. It got longer. I drop a beat. It's short. It gets longer. But actually, what you would find if you saw a longer strip is you would just see that the PR interval starts changing throughout your strip. It's not repeating that exact same pattern as it would be with the second degree type 1. And the other thing I'm going to tell you is if you're looking at this and you're saying, okay, could this be a second degree type 1 or is it a third degree? One thing that will truly help you with this is second degree type 1s or Winkie-Bachs are always an irregular R to R. And third-degree heart blocks will always have a regular R to R. So if those are the two that you're waffling between, sometimes that one rule will help. So on this example here, I see that I have a P wave. Here I have a P wave with no QRS, another P wave with no QRS, P wave buried in here. So again, I find two P waves I can see here and here, and I just march them out. The P wave to 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 P wave, it's going to march out. There's nothing wrong with the sinus node. It's cooking right along at its normal rate of 60 to 100 beats per minute. But the impulses aren't getting down to the ventricles. So now in this example here, you can tell that it's probably a ventricular-based rhythm that's coming up to help the ventricles because my QRS looks wide and bizarre. But QRS to QRS to QRS to QRS to QRS is regular. So here I have a R to R to R, which is regular. The rate is 40. It looks wide and bizarre. And so I'm thinking I have some type of heart block. And so now I need to go to my PR interval. This measurement here is not the same as this measurement here, is not the same as this measurement here, is not the same as this measurement here. And again, I know people frequently say, well, look, it's short, it got longer, I dropped a beat, and now it's short again. But that's actually not what's happened here. You have a short PR interval, you have a dropped beat. You have this measurement, you have a dropped beat. You have this measurement, you have a dropped beat. So it's not progressively prolonging and then dropping a beat. It's just a different measurement, showing you that there's not a relationship between them. So here I would actually chart this third degree AVB at 40. So you don't call, third degree heart block is the rhythm by itself. You wouldn't say I have a third degree bradycardia or I have a sinus rhythm with a third degree heart block. Third degree heart block is the rhythm, so it would just be third degree heart block at 40. Now this lower example here, I see I have a P wave. Now this here, I'm looking at it, it looks like a P wave, and I'm thinking, okay, is that a P or a T? But when I see here, my T wave is normally very flattened. So this is a P wave. So P wave with no QRS, P wave. Now, the other thing that you're going to notice here is a P wave would have fired right here. So sometimes you'll have P waves hidden in the QRS. It doesn't mean that they're not there. P wave, because P to P to P will march out. Here, R to R to R is marching out. My rate is only 30. And when I look at my PR interval, this measurement is not the same as this measurement, is not the same as this measurement. They are constantly changing. So this would be a third degree AV block at 30. Now this top one here, now this one example that I just showed you here, you can tell here this rhythm and this rhythm here, it's probably the ventricles kicking in to help pace something. So nothing's getting past the sinus node's getting to the AV node, the AV node's blocking the impulses out. Here it would be those Purkinje fibers kicking in to pace the ventricles. And I can tell that because my QRS is wide. I've got a wide funky QRS with the ST and T wave changes. And same here, wide QRS, ST changes. But when I look at this example here, I have a regular R to R. R to R to R is regular. My rate would be 1, 2, 3, 4, 5, so a rate of 50. I see that I have P waves. I have these extra P waves with no QRSs. So here's a P wave with no QRS, P wave with no QRS, so I'm thinking I have some type of heart block, and now I want to look at that PR interval. This measurement here, and then I have this measurement here, I have this measurement here, I have a constantly changing PR interval, so there's not a relationship between them. But here, I'm pretty sure it's the junction kicking in for me because my QRS is not over, it looks like it's less than 0.12. It looks like it's a little bit narrower QRS. And my rate's 50. So it looks like it's the junction actually kicking in to pace the ventricles. So it can look more junctional or it can look ventricular. But the key to this is I have more P waves than QRSs. R to R to R is regular. More P waves, but a constantly changing PR interval. This one here, I can see that I have more P waves than QRSs. And again, if I march these out, there will be hidden P waves even in this QRS or in the ST segment. It doesn't mean they're not there. So I have extra P waves. My QRSs, I only have, they're regular. It's only marked for 3 seconds here, so it would be a rate of 40. And so I think I have a heart block. And now I go to my PR interval. It's not progressively prolonging and then dropping a beat like a type 1. It's not fixed like a type 2. My measurement just keeps changing. And I know, again, like I said, many people say, okay, well, this is short. It got longer. But It's this measurement and I have a drop beat. It's this measurement and I have a drop beat. It's this measurement and I have a drop beat. So it's not progressively prolonging and then dropping a beat, which is what you would have in Winky Bach, or it's second degree type 1, which would also always make that irregular. Okay, this one here, I see that I have extra P waves. P to P to P marches out. R to R to R marches out. My rate looks like it's 40. So I think I have some type of heart block, and when I look at my PR interval, my measurement is just different. So this would make this a third degree AV block at 40. This one here, again, extra P waves. P wave there, P wave, P wave, P wave buried in here. So I see P to P to P marches out. R to R to R marches out. Again, my rate is approximately 40, because it looks like I just have markings here for a 3-second strip. And so I go to my PR interval, and this measurement is not the same as this measurement. It's not the same as this measurement over here. So it would be a third degree AV block. Now, what can cause a third degree block? Causes include a heart attack, open heart surgery, heart disease, fibrosis in the conduction system, infection of the heart like myocarditis, and ditch toxicity. The significance really depends on the ventricular rate. So they're symptomatic not because it's a third degree heart block, but because it's a rate of 30 or a rate of 40 or a rate of 50. So it's whatever the rate is. It's more ventricular rate dependent. If the rate is really slow, my patient, of course, they may be dizzy, altered level of consciousness, hypotensive, syncope, chest pain. They're going to show those signs of a decreased cardiac output. So I'm going to want to make sure I get vital signs, which should always include an oxygen saturation. Put them on oxygen if their O2 sat is low. I'm already monitoring them on the heart monitor. And I want to consider an external pacemaker if they're symptomatic until a temporary or permanent pacemaker can be inserted. Now, it's not that I can't try atropine. I can do atropine, 0.5 milligrams, but atropine does not usually work on a complete heart block. So usually we're going to tell you don't waste your time with it. Just go straight to that external pacemaker. And if you don't have external pacemaker availability, we would go straight to dopamine. Or you can use an epinephrine drip, but I would say dopamine would be more common. Remember, with an external pacemaker, if your patient's awake and alert, they're not very well tolerated. You're usually going to turn your pacer on. You're going to set your rate between 60 and either 60 to 70, and then you start turning the milliamps or the current up until you actually see the pacemaker fire, until you see capture occur. We would hold anything like digoxin or beta blockers, and of course we'll always look for the cause. What could be causing this? Because if we can find and treat the cause, that's going to be ideal. Now, I also put a heart block poem up here, and I'm sorry, don't know what happened there to my heart block poem. So with my heart block poem, it says, if the R is far from the P, then you have first degree. Longer, longer, longer drop, then you have a Winky Bach. If some P's just don't go through, then you have a Mobitz 2. If P's and Q's just don't agree, then you have a third degree. Some people like that. Anyway, I hope this helped with your third degree heart blocks.